Hello everyone, I am Dorina Esendagli and I work as an adult pulmonologist at Başkent University in Ankara, Turkey. I'm here today as a member of the editorial board of the Monograph as the early career member representative, and I'm very glad to welcome today the guest editor of the newly published monograph on pulmonary hypertension. We have here today Gabor Kovacs, who is an associate professor of respiratory medicine and works at the Division of Respiratory Medicine of the Medical University of Graz, Austria, where he leads the Pulmonary Hypertension Research Unit. Gabor's interests focus on pulmonary hemodynamics and pulmonary hypertension. He is an author of many guidelines related to pulmonary hypertension, and also he has led the task force on the definition, classification, and the diagnosis of pulmonary hypertension at the 7th World Symposium on Pulmonary Hypertension in 2024. Welcome, Gabor.
Thank you very much, Dorina, for your kind introduction and for the invitation to this podcast.
I'm very curious to know how you got yourself involved in this field.
Honestly, I started it 20 years ago in 2005, where I came for a one-year scholarship to Graz. In Graz, Professor Olszewski was leading the pulmonary department, and he had already a lot of experience in the field of pulmonary arterial hypertension and other forms of PH, and I wanted to learn from him and do some research for a year. But obviously, 20 years have passed so far, so this 1 year became longer and longer. First, it was prolonged with an additional year, then again with a year, and then finally we started also long-term projects, and I also started to work as a pulmonologist in Graz, and I am still here. So this shows that pulmonary hypertension may be really so fascinating, as well in the clinical part and also in the research, in the clinical and basic research, that this interest kept since then, and I am still very happy to work on this field.
And we are very happy that you got involved because you have contributed a lot in this field. Really, thank you for this. But as we know, many pulmonologists are not actually very specialist on the field sometimes, and they are even afraid if they are not enough to put a diagnosis right and how to follow these patients. So how does the monograph addresses especially the diagnosis for the population at risk? And how does the monograph guide especially the non-specialist professionals?
This is a very good question. But first, please let me thank my colleagues, Athénaïs Boucly and also Robin Condliffe, who were also editors of this monograph, but also from the editorial team who helped us a lot putting together this little book. And as you mentioned, this is not only for pulmonologists, because also colleagues from other disciplines have everyday contact with patients with pulmonary hypertension, and we are all interested that they know how to manage all these patients. And I remember that when I saw these patients and I read about these patients 20 years ago for the very first time, I was totally confused. So I can compare it maybe to hematology. This is another area of medicine where I am almost giving up when I try to understand the different subtypes of different hematologic diseases. It looked similarly complicated to me. But over the years, I realized that it's in fact very logical. And if you approach it in an interdisciplinary manner, then you will be able to help most of the patients. So coming back to your question, what is maybe most important for colleagues who are not pulmonologists? And I would like to mention here early diagnosis and appropriate diagnosis of pulmonary hypertension. It is really very important, and we all see patients with pulmonary hypertension and have to think of this disease. Why? Because the most important symptom of pulmonary hypertension is exercise dyspnea, which can be seen in many patients with frequent pulmonary and cardiac diseases. But some patients do not have these frequent conditions, but they have pulmonary hypertension, and it's important that we recognize it. Currently, we made a survey and found that the median time between the first symptom, which is exercise dyspnea, and the diagnosis of pulmonary hypertension takes 27 months. That means over 2 years. And this has not changed in the last 20 years. If you look at data from the French registry published in 2006, then the time between the first symptom and to diagnosis was exactly the same, 27 months. So although we talked a lot about pulmonary hypertension, we learned a lot on this disease, we have improved diagnostic tools, we still need increased awareness. That means that colleagues have to think that the patient may have pulmonary hypertension and make the appropriate diagnostic examinations, which is echocardiography non-invasively. So this is the most important non-invasive investigation. And if the patient has a suspected pulmonary hypertension based on the non-invasive investigations, then right heart catheterization in an expert center. So this is point number 1 for me. To think of the disease, awareness must be increased. Second, and this is also important also for not PAH or PH specialists, that these patients are complex and need to be managed in an expert center. A current study showed that there are only 10% of the patients who are really presented in an expert center with suspected PH. This number must be increased, so patients with suspected pulmonary hypertension need to go to the specialists who can make appropriate diagnosis and appropriate treatment.
Yes, it's very important actually, because these patients have not only a delayed diagnosis, but sometimes misdiagnosed as asthma or COPD, and they take inhalers or other treatments which are not related. So everything actually starts with a suspicion, as you mentioned. And it's the collaboration, the multidisciplinary collaboration that's important, not only in the diagnosis actually, but also then in the treatment and then the follow-ups as well, because the follow-up of patients is very important. We have to closely follow up them. And sometimes it's not the same for different patient groups who might have different progression trajectories. So can you comment on the importance that the collaboration of these multidisciplinary, let's say, professionals for pulmonary hypertension, and which are the fields which are a must to be included in this collaboration?
Just if you think of the clinical classification of pulmonary hypertension, and you immediately see that group 1 is PAH, which is a pulmonary vascular disease, but group 2 is PH associated with left heart diseases, so we immediately think of the cardiologist. Group 3 is associated with pulmonary diseases, so we immediately think of the pulmonologist. Group 4 is chronic thromboembolic disease in most cases, where we immediately think of the radiologists, of the angiologists, and of the surgeons or interventional radiologists. But also in group 1, where we have the pulmonary vascular disease, this may be associated with connective tissue diseases, where we again think immediately of the rheumatologists or dermatologists sometimes. It may also be associated with HIV, so we think of infectious diseases. It may be associated with portopulmonary hypertension, so we think of the gastroenterologist, and we also have such associations with hematologic diseases and so on. So really, nearly all disciplines of medicine occur already in the clinical classification. And if we put it in another way, when the patients with pulmonary hypertension first go to the doctor, they have dyspnea during exercise. So they go to the general doctor, to the house doctor, and then it's very important that these colleagues trained in general medicine think of pulmonary hypertension, know that such a disease exists, which can be the cause of exercise dyspnea. Then, of course, patients are diagnosed and managed in an expert center, treated by multidisciplinary teams, but then they need to go back regularly also to the general doctors, who then also take care of the patients. So both horizontally and vertically, somehow in different dimensions, we have to manage these patients in a multidisciplinary way. We need all colleagues for the best management of the patients.
Taking into consideration the spectrum of diseases which can cause pulmonary hypertension, it means that it's like a dynamic. I mean, who has to be included in this multidisciplinary team? It can change according to the patient, according to the symptoms. And for sure, I mean, we don't have most of the cases a pure pulmonary hypertension group 1 or group 2 isolated, but sometimes we have all of them combined, group 2, 3, and sometimes even 4. For example, in my daily practice, I do have such patients, and it is difficult actually to approach. So the multidisciplinary team is a must, I think. I am really curious to know if there were any debated areas in the field of pulmonary hypertension that you try to address in the monograph. You might give examples because I know there are many issues, but especially, for example, for the group 3, for the lung diseases, what are the areas debated now?
Well, we have many debated areas, but as you mentioned, and maybe for colleagues from the ERS who are mainly interested in lung diseases, this is one very special debated area. And as you mentioned already, we are talking about a spectrum in many cases. So in the individual patient, it is not always easy to decide if the patient has also other diseases, a little bit of COPD, maybe a little bit of left heart failure, but maybe a severe elevation of the pulmonary vascular resistance. The patient may be elderly, may have also arterial hypertension, and so on. So it is sometimes not so easy to say this is a group 1 patient or a group 2, group 3 patient, because we are individuals and all these categories are somewhat artificial. So what we try, of course, to do to classify these patients, and this is one of the current challenges, as you mentioned, group 3, which is PH associated with lung diseases or hypoxia, because here we have patients who are very frequently seen by doctors in the respiratory field and who very frequently have pulmonary hypertension, but where it is not so easy to say what to do with these patients. In ILD, we have one approved treatment, however, only in the USA. We do not have an approved treatment for PH associated with ILD in Europe. Several studies are ongoing and are going to be initiated soon, and I hope that this will be changed very soon. But in COPD, for example, which affects a lot of people all around the world, thinking that probably 6 to 8% of the world population may have COPD, and many of them may have pulmonary hypertension. And for this condition, there is no approved treatment at all. Sometimes, and this is also reflected by the guidelines, if we see severe pulmonary vascular disease, then in expert centers, an individual treatment approach may be suggested. However, we have to be very careful with these patients because they may also have side effects or complications of the treatment. So this is one currently very much debated area, how to treat best patients with pulmonary diseases and pulmonary hypertension. And this is also discussed in one of the chapters of the monograph. I hope that if you read that chapter, you will a little bit better understand what are the main considerations here.
Yes, it's important that we should treat people in an individualized base, as you mentioned. And the group 3 is really one of the groups that we feel like, well, we need some treatments choices because these are very fragile patients, especially when we have severe COPD diseases. So I want to ask you, despite of the treatment choices that we have, is there any other gap or anything that should be addressed in the research that should be focused in pulmonary hypertension in the future? What do you find is missing and that we should go on to research about it?
Yes, of course, there are many open questions. One of them, as I mentioned, pH associated with COPD and new treatment options. And I really hope that with some trials which are ongoing, we may have new data and evidence for treatment of these patients. But also there are other gaps, other open questions in the treatment. I'm sure many of you have heard that sotatercept, a new treatment opportunity, has been approved for the treatment of PAH by the FDA and also by the EMA last year, so 2024. However, our current guideline on the management of pulmonary hypertension in Europe, the ERS ESC guidelines, are from 2022. So we were not able to address this important new drug, which addresses a fourth treatment pathway, a completely new treatment pathway. We couldn't address this in the currently available guidelines. So there are some suggestions in the proceedings of the World Symposium, but it's not a guideline. And we all feel that it's very important that based on the evidence of the positive trials and other published data, we are able to make recommendations how to use this new drug and which are maybe risk situations where we have to be very careful. So that's why the ERS decided to produce new guidelines for PAH treatment. And here I have the honor to be one of the chairs together with Marion Delcroix and with Katarina Zedan. We are working now on these new guidelines with a fascinating group together. And we are very optimistic that next year, hopefully, we will have new guidelines on the treatment of PAH, where we will be able to find the right place of sotatercept based on the current evidence.
It's very good to hear that we will have a new guideline, because even though it's like 3 years ago, we had already a guideline, the pulmonary hypertension field is evolving so fast. So it's like we need to follow everything that might be a hope for our patients and which could improve how we treat them. I'm very curious to know, how do you see the future of the pulmonary hypertension management evolving over the next, let's say, 5 to 10 years? I feel that you are very optimistic, but what do you think will happen in the next 5 years, let's say?
I am optimistic, that's true. So first, in the field of treatment, you have to think of it that 20 years ago, when I started to work in the field of pulmonary hypertension, we just had a handful of drugs available for the treatment of PAH, and most of these few drugs were very, very new on the market. So before 2000, only large or high-dose calcium channel blockers were available for a very small group of patients, and epoprostenol, which had to be given intravenously 24 hours long a day. So beside these treatment options, we had nothing in the hand. And now, 25 years later, we have now a lot of drugs, great experience and great success with these drugs. Since last year, even a new drug from the fourth pathway. But we are not there yet. Instead of this incredible improvement in our field, we are still not there where we want to go, because we would like to heal our patients. So far, we are able to improve hemodynamics, to improve prognosis, to improve quality of life, really a lot. But we are not yet able to cure our patients. But I'm really optimistic that if we reached so far in these 20 to 25 years, then in the next 20 years, I hope we will be so good that we are able to heal our patients. The other thing is in the diagnostic part, because 20 years ago, when I learned pulmonary hypertension, the diagnosis of pulmonary hypertension ended with the right heart catheterization. That had to be done at that time, and that still has to be done. And I don't think that there is any meeting where patients are participating and the question is not coming, how long do we need to make right heart catheterization for the diagnosis of PH? And at the moment, I can just say we still need it. It's important because we have information from that examination that we cannot get from any other investigation. But we need to work on that. And here also I am optimistic that within the next years, we will hopefully have the opportunity to make this diagnosis non-invasively in a much easier way, where the delay between the symptoms and the diagnosis can be shorter and not that unpleasant for the patients.
It's very good to hear that we are optimistic in this field and that good things will happen in the future. I think that it was considered like pulmonary hypertension is a rare disease and like not everyone has to deal with it. But with the increasing of awareness, I think that we will have more patients because we are just aware of it. So finally, for clinicians and researchers who haven't yet picked up the monograph, what would you say to encourage them to explore it?
This is one of the most exciting fields of medicine. It is interdisciplinary, it has developed a lot, and there is a lot of potential for further development. So I really encourage everyone to read the monograph and to understand a bit better the field of pulmonary hypertension.
Thank you very much, Gabor, for being here today with us. And thank you for the very valuable information that you shared with us. And I hope that we will have another monograph about pulmonary hypertension, taking in consideration the development in this field. And I want to thank you, all the listeners, for being here today. And I would also recommend them to read all the chapters of the monograph to have even a more detailed information in this field. Thank you very much. See you.
Thank you.